We understand that while no technology can replace what you do, we believe our scientific advancements may help. The ANEclear anesthesia recovery device is intended to expedite recovery from the effects of volatile inhaled anesthetics by removing these unwanted gases and to increase your patient's spontaneous drive to breathe at the end of surgery. It is intended for use with only isoflurane, sevoflurane, and desflurane. This device should not be used with patients in whom hyperventilation by either increased tidal volume or rate would be contraindicated, or in those patients who would not tolerate increases in arterial carbon dioxide levels. This presentation will provide you with the most essential information regarding ANEclear and is formatted in chapters so you can easily navigate through the information. For more information, please refer to instructions for use or contact your ANEclear representative. Thank you for your interest in ANEclear. We hope this presentation will prove helpful to you. This presentation is broken into 5 sections: ANEclear setup, emergence protocol, monitoring with ANEclear, ANEclear use in spontaneous breathing patients, and ANEclear problem solving. ANEclear is designed with an activation switch so that it can be inserted into the breathing circuit at any time prior to emerging the patient. When deactivated, ANEclear is in bypass mode, adding only 8.5 milliliters of dead space into your breathing circuit. If applicable and desired, this bypass mode allows for ANEclear insertion prior to surgical draping. Premature activation of ANEclear during surgery may lead to emergence prior to surgical conclusion. Additionally, ANEclear can be inserted into the breathing circuit just preceding the start of emergence. It is recommended to fully extend the rebreathing loop before placing ANEclear into the breathing circuit to minimize the risk of inadvertently dislodging the endotracheal tube or laryngeal mask airway. Full extension of the rebreathing loop provides 750 milliliters of dead space to allow for maximum rebreathing of carbon dioxide and optimization of ANEclear benefits. Place ANEclear between the patient and the anesthesia breathing circuit, noting the visual image prompts on the device for correct placement. ANEclear can be used with either a dual limb parallel Y or coaxial tubing anesthesia circuit placed behind the device. The gas sampling port needs to be placed between the patient and ANEclear to ensure that the displayed gas readings represent the actual inhaled and exhaled gas concentrations of your patient. If the sampling port is inadvertently placed between ANEclear and the breathing circuit, ANEclear will still function properly, but the gas readings displayed of actual inhaled and exhaled gas concentrations on the monitor will be inaccurate. The placement of the heat moisture exchanger, or HME circuit filter, has minimal effect on the performance of ANEclear, but the performance of the HME filter is improved if it is closer to the patient. Therefore, it is best to add an HME or bacterial filter between the patient and ANEclear if desired. While weighing only 6.8 ounces, supporting ANEclear with an airway circuit holder will relieve strain on the connections to the LMA or endotracheal tube. Use the adult-sized slots on the tube tree since the smaller diameter pediatric slots can slice the ANEclear rebreathing loop. ANEclear will work with all anesthesia machines and monitors as long as tidal volumes of 500 milliliters or greater can be delivered and the emergence minute ventilation is double that of the maintenance. ANEclear can significantly reduce recovery times and increase the patient's spontaneous drive to breathe at the end of the case. This may facilitate recovery for patients who are overweight, elderly, or at risk of obstructive sleep apnea. If applicable, discontinue the use of nitrous oxide 10 to 15 minutes prior to emergence. Due to its small molecular size, ANEclear's absorber will not trap nitrous oxide. Immediately prior to emergence, discontinue the use of all volatile anesthetics. Discontinue air if being administered and increase oxygen fresh gas flows to 10 liters per minute. Note that the ANEclear device initially contains room air. Thus, an initial drop in the fraction of inspired oxygen may be seen upon activation. Adequately hyperventilate the patient. ANEclear can be used for all patient types and durations of surgeries if the patient can tolerate mechanically delivered tidal volumes on emergence equal to or greater than 500 milliliters and a slightly increased airway resistance up to about 1.8 centimeters of water at about 30 liters per minute. Emergence ventilation should maximize alveolar ventilation to expedite elimination of volatile anesthetic. If tolerable, emergence minute ventilation should at least double maintenance minute ventilation with an ideal tidal volume of between 650 to 750 milliliters when the rebreathing hose is completely expanded. Since hyperventilation results from increases in both tidal volume and respiratory rate, for most adults this will allow tidal volumes of approximately 600 to 800 milliliters, but the best combination depends on the patient's pulmonary physiology, limiting barotrauma, and the presence or lack of pathology such as restricted lung disease, COPD, etc. If the patient's calculated maximum tidal volume is less than 700 to 800 milliliters due to patient size, physiology, or pathophysiology, the rebreathing hose can be decreased accordingly. Tailoring the amount of rebreathing for each individual patient can be done by setting an appropriate tidal volume and then adjusting the rebreathing dead space such that the fraction of end-tidal carbon dioxide remains in the range of 50 to 60 millimeters of mercury. However, if there is mechanical difficulty or resistance in achieving adequate hyperventilation, if applicable, check both the inspiratory flow limit and inspiratory peak pressure limit settings on the ventilator in order to deliver indicated tidal volume breaths. If end-tidal carbon dioxide levels do not rise rapidly, first check for proper positioning of the gas sampling port between the ANEclear and the patient. Then consider reducing your tidal volume and increasing respiratory rate instead, as tidal volumes significantly greater than 750 milliliters tend to slow the rate of rise seen in end-tidal carbon dioxide levels. Remember, there will always be a delay after any change in ventilator settings, so confirm after at least 1 minute to ensure that your delivered minute ventilation has increased, as actual tidal volume can often be less than set tidal volume. For example, when inspiratory flow rate is inadequately set or the peak pressure limit is exceeded, actual tidal volume can be less than the displayed set tidal volume when the set tidal volume is not being fully delivered. Activate ANEclear by breaking the perforated clear tamper seal by sliding the switch forward to the fully on position. Make sure the switch has slid all the way to the activated position and completely covers the forward black arrow. If the switch is not in its complete on position, ANEclear is partially activated and your patient will not experience the full recovery benefits of the device. ANEclear only removes volatile anesthetic. ANEclear will not alter the elimination rate of IV sedatives and opioids. Therefore, clinicians should manage their patients' IV sedatives and opioid levels accordingly to plan for emergence. Finally, monitor your patient for the classic signs of emergence from inhaled general anesthesia and extubate based on your best clinical judgment. Other than the beginnings of a change to hyperventilated respiration pattern, your monitors will not look any different just before ANEclear activation. Once activated, you will notice 3 differences on the monitor. First, the carbon dioxide waveform, or capnogram, will almost immediately show rebreathing of carbon dioxide by an upward shift of the baseline waveform. Second, the fraction of inspired and expired oxygen will initially show a small initial drop due to introduction of room air that was contained within the ANEclear rebreathing loop. This short drop in the fraction of inspired oxygen, FiO2, should not be a major concern as long as oxygen flows have already been increased and monitored blood oxygenation remains adequate. Third, the fraction of inspired anesthetic agent will drop to zero, usually within 4 to 6 breaths, as the anesthetic gas absorber traps these volatile agents to prevent anesthetic rebreathing. Displayed values of both end tidal and fraction of inspired carbon dioxide will increase, representing the partial rebreathing of carbon dioxide. ANEclear causes higher carbon dioxide levels during emergence, which do not necessarily indicate insufficient ventilation. Continue to monitor the patient for the classic signs of emergence from inhaled anesthesia. After ANEclear activation, the displayed fraction of inspired agent will quickly decrease to near zero. The end tidal agent level, while never reaching zero due to the agent being steadily eliminated by the patient through expiration, will rapidly decrease to less than MAC awake levels due to its active clearance by ANEclear. If adequate, hyperventilation is applied and the patient is not encountering the effects of too much opioid or muscle relaxant, emergence can occur at any moment. Be ready, as emergence can occur up to 50% faster. Some patients will possibly not exhibit the common signs associated with emergence, such as prolonged coughing or stage 2. ANEclear provides for a safer and faster emergence from inhaled anesthetics in spontaneously breathing patients. During emergence in your spontaneously breathing patients, an activated ANEclear utilizes partial rebreathing of carbon dioxide to raise the partial pressure of carbon dioxide in the blood. This respiratory stimulant increases the patient's spontaneous minute ventilation, which accelerates clearance of the inhaled anesthetic from the lungs. This same respiratory stimulant, PaCO2, will also increase cerebral blood flow velocity. This is especially important while under the influence of inhaled anesthetics and opioids due to their respiratory depressing effects. Some of these drugs are opioids, benzodiazepines, nitrous oxide, and neuromuscular blocking agents. At 30 liters per minute, ANEclear adds 1.8 centimeters of H2O airway resistance into the breathing circuit. This added resistance minimally increases the work of breathing for a spontaneously breathing patient, as ANEclear is typically a very small percentage of the total circuit resistance. This added resistance is comparable to adding an additional large diameter bacterial filter into the breathing circuit. Emphasis on maintaining adequate delivered tidal volumes of at least 500 milliliters is vital in the safety and efficacy of ANEclear, especially in spontaneously breathing patients. This tidal volume level will provide adequate oxygenation during rebreathing. If tidal volumes are less than 500 milliliters with the rebreathing loop fully extended, it may be possible to continue the use of ANEclear if the patient tolerates tidal volumes less than 500 milliliters. However, special attention should be paid to both the fraction of inspired oxygen and oxygen saturation. If FiO2 drops below 35% or oxygen saturation drops below 90%, ANEclear should be deactivated. In order to obtain maximum benefit from ANEclear in a spontaneously breathing patient, it may be desirable to augment their tidal volume by bagging or using pressure support mode ventilation if available. These methods will increase and optimize minute ventilation. Patients in which minute ventilation is disrupted by excessive coughing could also benefit from synchronous intermittent mandatory ventilation to augment baseline ventilation while supporting spontaneous attempts. Additionally, LMAs in spontaneously breathing patients are less stimulating and can cause less coughing. Therefore, LMAs usually provide for the best environment for maximal ventilation and removal of inhaled anesthetic in a spontaneously breathing patient. Ensure the patient's minute ventilation remains intact when discontinuing SIMV or pressure support ventilation before removal of the LMA. In spontaneously breathing patients, where maintenance and tidal carbon dioxide levels are above 45 millimeters of mercury prior to emergence, activate ANEclear with the rebreathing loop contracted. This will minimize the dead space of ANEclear to 400 milliliters and allow for the clinician to control the amount of partial rebreathing and best manage the extent of hypercapnia. The rebreathing loop can slowly be expanded to increase the amount of rebreathing and levels of rebreathed carbon dioxide when it has been determined that higher carbon dioxide levels can be tolerated. Use a bite block. In vigorous spontaneous ventilation, biting on the endotracheal tube or LMA could greatly increase the chance of a patient experiencing negative pressure pulmonary edema. Discontinuing ANEclear before the patient is completely awake can slow recovery. Monitor your patient for the classic signs of emergence from inhaled anesthesia and extubate based on your best clinical judgment.